Hello, everybody. Welcome to the Powered by Patients webinar featuring Dr. Rebecca Donnelly from the UK. We're very excited to have her today to share some of her thoughts about how she's incorporating telemedicine within her practice and some of the innovative ideas that she's been able to incorporate and how that's made a difference in how she's able to take care of her patients. Welcome, Rebecca.
Hi, Mike. Thanks for having me. Thank you, Alison, for having me. I hope our connection is okay. There's a storm of brewing outside, so it might be a little shaky.
Well, we can certainly deal with shakiness, and we will absolutely do our best. We're hearing you
a little shaky,
loud and clear at the moment, and we will just do our best. And if we have to reconnect, we'll do it again. Thank you for joining us. I know that it's getting close to supper time there, and we're hoping to get some good insights. But before we get started, I'm an optometrist in the southern United States, and you're an optometrist in the UK. But before we go too far, just tell us a little bit about your practice. What's your day-to-day activity like in your practice?
Yeah, so I am the clinical lead of a group of independents in Bristol, England. This is my wonderful team here in this photo, pre-COVID.
Okay. Rebecca, I'm not seeing your slides. Is everybody else seeing them?
Let me just...
So we'll need to reshare the screen. I got to get a look at these, this team you're talking about. There we go. Now we're seeing it. There. Oh, that is a rambunctious bunch.
I'd hate to leave them out, So we are very lucky. We have a number of specialist clinics within our practices: dry eye, glaucoma, macular degeneration, contact lens, medical contact lens fitting. So our day-to-day practice is quite varied, which is good. And we're very lucky as well in that we have what's called therapeutic optometrists working for us. So we can treat and manage a lot within our practice. And I think that's different to how things are in the US. But here in the UK, optometrists can't always manage conditions therapeutically. They would need specialist qualification to do so.
And you guys have some of those specialists?
Yeah. Mm-hmm. So all of our optometrists are currently undergoing training, but myself and the two owners of the business are currently therapeutic optometrists.
Well, that's great. So is private optometry versus corporate optometry a big concern in the UK?
I suppose we have large chains of optometry practices here. And what they offer is very, very different. So what we offer, like all the specialist services I mentioned, I mean, these chains don't offer that type of care. So as I said, we're very lucky. Our day is varied, but also we offer a niche market to our community.
Great. Well, so what are some of the other differences in the way you would practice in the UK compared to the United States?
Yeah, so I think the main difference is what I mentioned about therapeutic optometrists. So optometrists are not called doctors in the UK. They may have a PhD and they may refer to themselves as a doctor, but as I said, generally, unless they have specialist qualification in independent prescribing or therapeutics, they cannot manage a condition. Therapeutically, they must refer for management or specialist opinion in the form of an ophthalmologist or a therapeutic optometrist. We also have the wonderful NHS, and the NHS cover a basic eye exam for under 18s, over 60, family history of glaucoma, diabetics, and people on income-related benefits. So this is that everyone can avail of eye care, which is great, but most optometrists will offer specialist services which are not funded by the NHS, but patients can pay for out of their own pocket if they wish to do so. And they would be the type of specialist clinics I mentioned that we do, or myopia management for kids, better glaucoma screening, better macular imaging and analysis.
Okay, and the NHS stands for?
National Health Service.
Okay, so the National Health Service, and so it's a, um, and that covers everybody within the UK, and it's whether they're in certain age groups, whether they get certain benefits that qualify them for eye exams, et cetera. Is that kind of correct?
Yeah, exactly.
And and the majority of your citizens have this coverage.
Yes, well, so the majority would, I suppose 50-50 of who we see would be NHS or private, but many NHS patients will choose to go private for specialist services.
Got it. Okay. All right. So it's a lot of the same complications, just a different variety, I guess, in how to deal with that. And do you have a preference on whether they would use their NHS or their private insurance?
So I think anyone who has any needs other than basic eye exam should be paying for a better eye exam
Got it. Okay.
if they
Well,
can.
yeah. Well said. Well said. And so, and you fit glasses and contact lenses in addition to all this specialty care that you deliver with dry and glaucoma. You do glasses and contacts as well, right?
Yeah.
And we want to focus in a little bit on how you've incorporated teleoptometry into your practice to sort of enhance the relationship that you have with your patients, to sort of add value to the care that you're able to deliver. Can you help us understand how you're doing that?
Absolutely. So I'll just go through with you about how we fund telehealth first.
Okay.
So I mentioned that we have private and NHS care. We provide NHS and private care within our practice. We're not just a private practice, but we have developed an eye care plan called iSense, and it's a bespoke eye care plan based on the patient's needs. So if I have a patient who is -9-ish prescription, glaucoma suspect, mild to moderate meibomian gland dysfunction, and wear soft monthly multifocal contact lenses, then they would pay about £30.50 a month to cover their annual appointments. So it's based on an annual fee, and it's very simple, or so it's based on an hourly fee, and it's very simple maths for us and for the patient. So telehealth is only available to our patients on an eye care plan. It's seen as a perk of being a member of our eye care plan, but also the financing is straightforward. So if that patient is due their contact lens check, but their sight test is within date, they would be offered a remote appointment, and they will have already paid for that appointment under their monthly payments. So we offer, I've kind of answered your question about what we do there. We offer remote care for contact lenses and for dry eye, but I know everyone here is more interested in how we use it for contact lenses.
Well, yeah, before we go too far down the contact lens road,
Yeah.
let me just ask you about this plan just a little bit.
Okay.
Because that is very, very interesting to me. So this is a plan that your practice has created. Is that correct? So it's basically the eye care plan is an agreement between the patient and the practice. And depending on how many conditions that they have already been diagnosed with, determines the monthly fee that they pay, and that gets them the care that they need.
Yeah.
And if so I don't know if this happens in the UK or not, but recently I had a patient who was actually scratched in the eye by his dog. It was a police officer who had a dog, and it scratched him. And so that was unexpected, not on the plan. But if he was on this plan, would that be something that would be covered, or would that be something that would need to be taken care of separately?
That would be covered. So if you're on the plan, urgent care is covered under your plan.
That is outstanding. And okay, so we're going to get into this contact lens thing. And so we want to ask many people on the call also take care of patients with contact lenses, me included. And so we have a poll question that Allison's going to put up, and we're just going to sort of ask everybody what their routine is. And so the question is how do you handle contact lens follow-ups? So you can either put one choice. So if you change someone's contact lens prescription, you give them trial lenses, and before you either you give them, it's a new prescription or you're changing it. So how do you do this follow-up to make sure that everything's working well? Do you require that they come back? Do you require that some of them come back to the office to follow up? Do you do some remote, or do you just not bother with follow-ups? So if everyone would just go ahead and answer that question, we'll give you, it's pretty simple. I know that there's not a clear-cut answer, but just pick the best one. You know, sometimes it'll be different. So pick the answer that's the best, and let's see how everybody votes. So it's interesting about these webinars. It is, we do have an international audience. And so it's interesting to see how people answer from all over the world, really. And so, Allison, my question went away, so I don't see the results. Do we have them there? Yeah, we do have. So still, most people are requiring, at least some of the time, some all the time, that the patient comes back into the office. And I don't know if you voted or not, Rebecca, but but we did have one that is providing the remote care. So everybody's doing some sort of follow-up. So that's interesting. Those are interesting results. So if you will share with us how you're able to do this.
Yeah. So during the lockdown, remote care was the only service that we could provide. And when we were allowed to see routine patients again, and when we could start fitting non-medical contact lenses again, remote care had become an expectation, and we had a capacity issue. So there was temporary guidance to allow for remote contact lens care. So this led me to start a soft contact lens remote aftercare clinic. So we actually do not just trial follow-ups, but annual soft contact lens aftercare follow-ups remotely currently. I'll explain the process and why that is a little bit later, but we have strict protocol for booking these appointments. They need to be a soft lens wearer, so we know that RGP wearers can have their symptoms masked by corneal desensitization, so they're ruled out immediately. They need to be 18 or over, and known patients to us, and asymptomatic, and a daily wearer rather than an extended wearer. So we're not putting any kind of risky patients into this remote aftercare group. We're seeing them face to face. We also do contact lens teaches remotely, and we check in on our trial lens patients remotely using the CooperVision My Lens Life. So 20% of contact lens wearers will drop out of contact lens wear within the first month. And for a CooperVision study said that 46% of contact lens wearers would have liked to have more contact from their eye care professional during their trial period. So this app is really useful, and hopefully will improve compliance and reduce lens dropout as well. So what we do for these soft contact lens aftercares, I'm talking about the annual aftercare, we have this process. Now, I'll just explain the situation with regards to COVID here in the UK. So we were given a traffic light system for recovery from the College of Optometrists. So we had a red phase where we could only do emergency eye care. And then in June 2020, we went into an amber phase where we can do symptom-led care. Remote care is recommended in certain cases using your professional judgment. We are still in an amber phase. So we've been in an amber phase for over a year now. Our temporary guidance allows us to carry out that remote care, like I said, using our professional judgment. And the General Optical Council have said that remote care is here to stay. So we know that it is looking positive that when we move into a green phase, that remote care will still be available to us. But I'm sure guidance will be improved and an evidence base will be there for us, so that all of the blind spots within remote care, there's more answers to that, and we can use that to build protocol. So our process currently, and this may change in the green phase, whenever that will be, our process currently is that when a patient gets a reminder for their appointment, their contact lens appointment, that they would ring up or book an appointment online, and the team would check if their eye exam is within date. So we can't provide contact lenses if a contact lens checkup or eye exam is not within date. So if their eye exam is within date and they have no symptoms, no concerns about their lenses, their vision, or their eye health, the team offers them a remote appointment. And if they agree to have that, if they like the sound of it, then they're booked in for a remote appointment in a remote clinic. So this is a huge tip for anyone considering to do remote care. Don't have it scattered throughout your diary. Have one half a day or a day of just remote appointments. You don't need a testing room, so you can do it in an office. So you can have, if you have 2 testing rooms, you can have 2 optometrists testing and a third optometrist in an office doing a remote clinic. So it adds a clinic to your diary, okay? And the testing time obviously isn't as long either. So you can double the amount of contact lens patients that you're seeing in a day if you're seeing them in a remote clinic. So when the patient is booked in for their appointment, an email is generated from AOS with their PIN and their activation code for their app. And an email is generated from our booking system as well, with very clear instructions on what to do, how to download the app, what's going to happen, what we need them to do before the appointment. And that was very carefully worded and took a while to get it right. But now it is seamless. And before the appointment, the patient sends a video of their push-up, because they can do video capture now with the new AOS version. And they send a photo in primary gaze looking up with the lower lid pulled down, and looking down with the upper lid pulled up for each eye. So on the day of the appointment, all I have to do is click video consult. The photos are there. The patient is already waiting for me in the video conference, and we do their remote consultation using a questionnaire that we made ourselves, and we put a lot of effort into making this ourselves, but I know AOS have a questionnaire available on their new version as well. I haven't used it because prior to that being available, we had made our own, but we'll probably continue to use ours, given that ours is based on what we want to get out of our remote care. If there's any concern, a patient is booked in for face-to-face. Thankfully, I have never had to book a patient in from a remote appointment face-to-face. I've never had anyone
not once.
Never, no. So that's been good. It means my team are doing what they should be doing and booking the right people in. And the recall is extended. And just on this point, I'll just remind you again, we're in an amber phase, so we're working on temporary guidance, but we know that guidance will come, that's more permanent. So currently the recall is extended for 12 months or to align with the next eye exam, whichever is the shortest interval. So we're still being quite cautious on our recall periods for the patient. And then lastly, we send the full report to the patient, including the imaging, and they can see everything. So we copy and paste the template into their AOS record, and we analyze the imaging, and I'll show you some photos of that as well. And then that's all sent to the patients. They can see everything that's been done, and the response has been really, really great. They enjoy seeing what we do, and they understand that contact lenses is actually a specialty in itself. Whereas before, they never realized why they needed 2 appointments, one for their eye exam and one for their contact lenses. So there's some education there.
This is outstanding. Thank you so much. Let me just ask a couple of questions. I was taking notes old school while you were talking about this. It was really, really intriguing. So I just want to sort of see if there's anything missing from this process that we would endanger in any way or put the patients at any additional risk. So first of all, you limit the type of patient that is available for this kind or can access this, to relatively low risk type patients. You schedule them, and I loved your tip about scheduling them in a remote clinic, because that can be anywhere. You no need to tie up an exam room to do this. So you're sitting in what doesn't appear to be in an exam room, but it could certainly be a remote clinic, right?
Mm-hmm.
And then you're checking with the patient, so you're asking them a number of questions. You're communicating with the patient, so you're actually able to talk to them. But you also have these questionnaires which sort of fish for complaints of things that could be going wrong, right? And I'm sure, and you worked on it. It sounds like you adapted it several times based on instructions, from the patients or things that you had to re-explain. So you've got the instructions down, you've gotten them connected. You're able to get centration of the contact lens by having them look in primary gaze. You're able to get movement by pushing up on the contact and getting a video of that. You're able to see the cornea, not with a slit lamp type view, but you can see if there's anything really bad. You can evaluate the redness, and you talk to them. And if anything goes wrong, you schedule them to come on in. And then what's intriguing to me is that you've been doing this for a year or so now, over a year. Is that right?
Yeah.
And you haven't had one complication that required that they come on in. So here's the big question is, when it goes green, what are you hoping that will change?
Well, I'm hoping it doesn't change, right? So I think that when we move into a green phase, that remote care will stay as it is. But we'll have more guidance and evidence to base these decisions on. And that's really what puts people off right now. It's the fact that they don't have very black and white answer about what they should and shouldn't do. And this is where AOS is great, because AOS, with that report as well, when the patient is seeing that, it adds so much value to that appointment. And the patients, I can see a cat coming at me from one side here, sorry. And the patients can appreciate that. Whereas, there's a lot of places offering remote care in the form of a phone call between patients in their fully booked clinic. So, this is taking the time to limit the risk, and we have the tools to limit the risk for us and for the patient, and to make this a legitimate way to check in on our patients routinely.
I would say in many ways it's better than the care that they may get coming into the office. I think you're probably giving them more attention. And the report, were you giving any kind of report for in-office contact lens follow-ups, if you will?
No, just a copy of their prescription. So now they're getting so much education from the experience. They come in. I had someone the other day, and they had their remote appointment a year ago, and then they came in today for their face-to-face, and they understood what I was doing, and they were more intrigued. They were asking more questions, like, well, what's this dye now that you're using? And they appreciated it far more than what I had noticed them to do in the past.
Would you say that this method has helped you enhance your relationship with your patients, or has it deteriorated those relationships?
No, it's enhanced it, especially now we're all wearing masks coming in. They can't see my face. New patients don't know what I look like.
Right.
And you have this, we're also so used to talking via a video conference now. We have social Zooms and speak to family using Zoom now. FaceTime is more popular than ever. So to be able to sit down and have a conversation with your patient with no barrier of a face mask, and be present in the comfort of their own home is great. They really enjoy it. They really love it.
Great. Thank you for that input. You said you had some images for us to see?
Yeah. So this kind of goes to what you were saying about trial follow-up. So one of the things that I think a lot of optometrists like to see in practice from a trial are toric contact lenses. They, because you want to see the centration of the lens itself. So with the new AOS toric marker, you can detect that with a photo that the patient sends in. So for example, to easy step into remote care, you have a patient who has -1 cils, but they're in spherical lenses. They're missing a bit of clarity, and you want to add the sil in and keep them in the same lens choice, same lens material, same modality of wear. So you can order lenses, patient collects them, takes them home, notices the vision in the right eye isn't great compared to the left, takes a photo of the lenses. You can adjust it, you don't need to see them, and then do a remote care 2 weeks later. and see that the lens is centered in their eyes after you've made that adjustment. So with this one, you can see the lens is about 30 degrees rotated, so we can make that decision remotely. I don't need to get them in for a 20 or 30-minute appointment just to see that the lens is decentered, only to have to order another set and get the patient in again. So there's so many small things that you can use it for that will really save time as well.
That's great. And what are these images that with the blue and the red and all this on the in the other image?
So that's the conjunctival hyperemia grading. It's an objective grading system with AOS, and actually there's been studies done on this with AOS used as the grading tool. There's lots of different studies on objective grading systems, but there's one where they use AOS in particular, and it has very good repeatability. I think there's something about the app when you're taking a photo. I don't know, Alison, you might be able to answer this. When you're taking a photo, the app works to try and standardize the image, but I don't know how it does it or what happens there. But I know someone has told me that, and I have read it. I just can't remember the details.
It's AOS magic.
Yeah.
AOS magic, that's right. But it sort of puts it into the graph, no matter what it is, the image can demonstrate very well, just like the report that you're talking about is able to demonstrate to the patient improvement or changes or what we're monitoring, the technology that we're using. So it's really, really interesting. But I think the point that you're bringing up is while I can imagine doing an in-office visit for a contact lens evaluation, yes, my slit lamp can see all the layers of the cornea that I can't necessarily see with a cell phone image, but I certainly don't have this technology to show me the number of degrees of rotation of the contact lens and all of these other abilities to make adjustments. And as you were talking, it made such great sense, Rebecca, when you said there's no need for a patient to come in for a 20 or 30-minute visit so that I can change the contact lens based on what I could do on the phone. But that doesn't even include the time that they have to take off work, to schedule an appointment, to drive across town, to find a parking place to go in and then go back. So much more convenient for the patient the same way. And I don't really see any sacrifice in the quality of care that you're delivering.
No, especially not for this type of thing, or, even if you changed from one toric to another just to help with comfort. When you can assess the rotation is what is in my mind when I order a lens for a patient. It's toric lens, and thinking, oh, I better see this before they go away with it. Whereas now I don't think that at all. They can take them away and try them. I mean, most of the time it's fine. So,
right.
But it's only the odd patient where it is rotated and they do have visual difficulties, where you're just eliminating a whole lot of time and effort for them and for you.
Right. So it's better for the patient, certainly as far as convenience goes.
Mm.
Well, this is just outstanding insights. So tell me, are there any things that if we wanted to get started with this, obviously you've put a lot of work into this and that you were sort of forced into it. You've also mentioned that there are things that you hope don't change about this when it goes to green. You're hoping you're able to hang on to the lessons that you've learned and incorporate it and continue to improve the care that you give to your patient. But if I'm not doing any of this and I'm doing everything the same way that we used to, how would I get started? What's the best way to implement these changes into our businesses as we go now?
I think definitely start with the trial follow-up. So a patient that's already known to you, that already has a history, and have trial follow-ups, and just book half a day in 2 or 3 weeks time, and book those patients in for remote care. Book more time than you need so that you can get your head around the system.
Okay.
But generally our appointments are 15 minutes, and that is not using all the time that you're necessarily conversing with the patient, particularly for an end of trial. It doesn't take that long. But you're also writing the report, and there's abundant time there to get everything done and all the admin involved as well. So start small and then work your way up, just based on your comfort levels and based on evidence that will emerge over the next year and guidance that will emerge over the next year.
Great. That sounds great. And as far as the scheduling goes, you mentioned your remote clinic, and I just wanted to go back to that just for a second. So when you say remote clinic, you're saying that the optometrist has time dedicated to these types of remote exams rather than trying to work them in between exams or glaucoma checks in the office and these type things. Is that right?
Absolutely. Yeah. You're just doing half a day of remote appointments or a day of remote appointments, because you need to be in that mindset, and it's too much to be coming in and out of them. I think, another person might not mind, but for me, I like to have my dry eye clinic as my dry eye clinic and my remote clinic is my remote clinic. I don't mind interchanging glaucoma and AMD and whatever it might be, normal eye exam. But with those, you need to be in a certain mindset for them.
So I know we're kind of at the end of our time together, but you brought up dry eye, and a couple of our other speakers have talked about how they've treated dry eye this way. Do you do any of your dry eye treatment or follow-ups or conversations utilizing telehealth?
Yeah, so for any new dry eye patient, we do a follow-up 3 weeks later using the app. So we have a conversation about their management plan, if they can remember everything they're supposed to be doing. And also it gives us that option to up our game straight away in terms of how aggressively we're treating the dry eye. If after 3 weeks, they might have come in and had a gland expression, 3 weeks later, no improvement, then I'm going to want them in for IPL or doxycycline, or, we don't need them sitting at home and happy for 6 months until their next appointment is due.
Great. And it sounds like it's another opportunity to enhance and build those relationships with your patients.
Yeah, absolutely. Yeah.
Well, great. Well, I don't know if we want to try to open up for questions, or if we have that. We failed to mention it, but we do have a question tab. If you've got time, Rebecca, to answer a couple of questions that may come in from the audience.
Yeah, no problem.
So, Allison, I haven't been watching the question list, but are there any questions that people have that have been rolling in at all?
I don't see any. I guess Rebecca is completely thorough, which is so great.
Absolutely, and that's partially my fault because I failed to mention the fact that it was there. But it certainly was thorough, and I've been really intrigued by some of the concepts. I love the eye care plan that you developed. I forget the name of it already. iSense, is that what it's called, Rebecca?
That's it. Yeah.
iSense plan. I love that idea, and love the way that the recommendation that you've given. The 2 recommendations that I want to make sure that I take from this is the scheduling the remote clinic, isolating that time away, and there was another one that has sort of slipped my mind, but I wanted to make sure I forgot, and I failed to jot it down. But
Start
another
small.
great big point: start small. That's right. That's start. Well, listen, thank you so much for your time, and thank you for coming to us in your evening and helping us understand how to expand our horizons a little bit. You've been a great guest, and we really appreciate having you.
No problem. Thanks for having me. I really appreciate it as well.
Great. Thank you. Allison, is there anything else?
Oh, so much, but we're out of time. But thank you, Rebecca. Such great insights to share. And thank you, Mike, for hosting, and for everyone to carve out a little bit of your time today to learn from Rebecca and Mike. So thank you.
Great. Have a great evening.
Thanks.
Thank you. Bye-bye.
Bye.